Good afternoon. Thank you for joining us for this multimodality imaging conference. Today we will talk about imaging of hypertrophic cardiomyopathy patients. Please take a look at that code, scan it, so you can get credit for attendance. So my goal today will be to present an imaging approach that is goal-oriented. What information do we get to glean from imaging, and how does it serve the diagnosis and the management of these patients? The hallmark of hypertrophic cardiomyopathy by histopathology is the presence of hypertrophy, unexplained hypertrophy, so there is no reason to account for it. For example, severe aortic stenosis or uncontrolled hypertension should not be present. So there is a clinical piece that is needed when we interpret echocardiograms that we have to be aware of. The presence of fibrosis, and fibrosis could be interstitial fibrosis in between muscle bundles as well as surrounding muscle fibers, but could also be islands of replacement fibrosis for myocytes that have been lost. And then the presence of myofiber and myofibrillar disarray. We do a good job, as you will see, with imaging in looking at hypertrophy, fibrosis, and there is promising work with CMR to look at disarray. So what are the goals of imaging? One is evaluation of patients with increased wall thickness. One group of patients will make it to the imaging labs because wall thickness is increased. Not every increased wall thickness is hypertrophic cardiomyopathy. We want to assess myocardial function, systolic and diastolic function. Patients with hypertrophic cardiomyopathy can have dynamic obstruction. About 2/3 of them may have it at rest or with provocation. There are also various grades of mitral valve disease that can be present. Imaging plays a role in risk stratification for sudden cardiac death. Some patients can have symptoms of chest pain, and the question of ischemia arises. And then as they get treated, we frequently use imaging to see the response to treatment or in the initial selection of treatment, or to guide procedures, as you will see, and then screening of first-degree relatives. So going to morphology, morphology is looking at the dimensions of the ventricle, the volumes, and the wall thickness. This is from the multimodality recommendations from the American Society of Echo in 22, and it shows how measurements of thickness is performed. It is very important when we measure thickness not to include muscle bundles from the RV side. You have to be careful also with off-axis views. These oblique views can result in increased wall thickness when actually it is not increased. One way of figuring out how the orientation is and how good it is, that cut, is to go back from para-long to para-short. Notice that a difference here in the measurement from 13, that's an erroneous measurement, to 10 for the correct measurement, in someone with a positive family history can be called positive for hypertrophic cardiomyopathy. So it is critical that we pay close attention to our measurements and the quality of the images that we get and analyze. Asymmetric hypertrophy and reverse curvature phenotype are pretty sort of outstanding if you see them. And you can see, if you see a case like that, it's sort of not a challenge. Most cases of hypertrophic cardiomyopathy will have the asymmetric pattern if you would have hypertrophy, not the concentric pattern that is shown here. Sometimes we read reports that says concentric hypertrophy. If you see a patient, say, with hypertension, the hypertrophy pattern that you see in these cases is more frequent concentric rather than asymmetric, but maybe 3 to 5% at most of cases of hypertrophic cardiomyopathy can have concentric hypertrophy. Apical hypertrophy can be a challenge. This is scanning the apex using a high-frequency transducer. And we use the high frequency to get a good resolution at what is happening here in the apex. It shows it nicely, the hypertrophy. If you have an image like that, the diagnosis is not a challenge. The challenge comes in many situations where we do not see the apex clearly. And so we use ultrasound enhancing agents, and you see the stars noting the presence of apical hypertrophy in the distal, lateral, and septal walls. It's a big omission to miss an apical hypertrophy patient, and sometimes clinical presentations and EKG findings draw attention to that. So that's a summary for the hypertrophy patterns that we've been talking about. There is the basal septal hypertrophy, which is not uncommon. We get quite a bit of referrals where patients have hypertrophy of the basal septum. You don't see much of hypertrophy distal to that basal segment, and it's involved with dynamic obstruction. That's the reverse curvature. There is the patient here with apical hypertrophy, and there is the formation of apical aneurysm, and then massive concentric hypertrophy. Not every increased wall thickness, as we were talking, is equal hypertrophic cardiomyopathy. We have to look at clinical findings and some other imaging findings to arrive at these. CMR also is used to measure wall thickness, and similar to echocardiography, one should be careful in how the measurements are obtained, as off-axis and erroneous measurements can lead to false goals of hypertrophy when none is present. Short axis cut showing clearly that the septum is much thicker here than the lateral wall. Dr. Mann will get into that. There is apical hypertrophy by CMR. A feature that is recognized easily or readily by CMR is the presence of crypts. They are frequently present in the inferolateral wall. They have been described in patients who carry pathogenic mutations but who do not manifest hypertrophy, and so could be clues to the recognition of these cases. Having said that, some normal individuals can have these crypts. CT scan can be used. Sometimes we have patients who have pacemakers or other tissue or foreign material, if you would, in their body that precludes doing CMR, or they are claustrophobic. You can do cardiac CT. Example of asymmetric hypertrophy in long axis and short axis views, and there is apical hypertrophy by cardiac CT. So the point is, if the echo gives you a clear picture of the hypertrophy pattern, well and good. If not, CMR is your next option. If the patient is not a candidate for CMR, then CT, and the requesting provider needs to state, this is what I am looking for. So the lab is on the alert to get the proper images. There are many indices of systolic function that are used in all cardiovascular disorders. The ones that you will see frequently in reports are fractional shortening, ejection fraction. Ejection fraction is a big deal in this disease because we can identify patients with reduced ejection fraction, be it part of the natural history of the disease, where a small subset can develop systolic dysfunction, or changes in response to negative inotropic therapy with myosin inhibitors, for example. Once the dilated hypokinetic phase of the disease develops, that's a very different outcome than from classic hypertrophic cardiomyopathy, and clinically they are treated the way you would treat someone with a depressed ejection fraction with for example, the ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, etc. And also they would be candidates for defibrillator ICD implantation. At first there was a look at myocardial velocities. Later on it sort of gave way to the use of strain, and a routine measurement obtained nowadays in most labs is global longitudinal strain. It's obtained from the 3 apical views, and that's an example showing you a patient with hypertrophic cardiomyopathy with a profound reduction in global strain, about 7%. Global strain has been associated with adverse outcomes, but per se is not an established marker of sudden death. So we routinely acquire it, and we routinely include it in the report of these cases. The strain pattern can also give insights to the hypertrophy pattern. So that's a patient with septal hypertrophy, and you see the reduced strain in the septal segments. In contrast, this is a patient with apical hypertrophy, and you see the reduced apical strain. Diastolic function assessment, echocardiography is really the main tool that is used. One can get filling rates. Sometimes you can get mitral and flow velocities and even annular velocities by CMR and CT, but they have lower resolution and probably wider confidence in the measurements that you get from them. This is a pressure recording from a patient in NYHA class 3 to 4. You see very high minimum pressure. The normal is close to 0. This one is about 17, a pre-A pressure that is very similar to the left atrial pressure of 24, and a huge rise in the late diastolic LV pressures with an EDP in excess of the 30s. The corresponding tissue Doppler counterpart and mitral inflow, this case, you see a mitral E velocity of 100 and an annular velocity of about 6 and a high E to E prime ratio. So that's one of the tools we use. Another interesting observation that parallels the increase in the end diastolic pressure that you saw in the previous slide. Look at the mitral A and look at the pulmonary vein atrial velocity. When the atrium contracts, it sends blood forward across the mitral valve, and if the late diastolic pressures of the ventricle are elevated, that A velocity has a short duration, small amplitude, rapid decay with a short decel time. In comparison, much less resistance is offered by the pulmonary veins when that left atrium contracts, and you see this atrial velocity approaching 40 centimeters per second and a much longer duration than that of mitral A duration. So that's a useful signal. We have a statement in our routine reports where we say pulmonary vein pattern consistent with increased LV and diastolic pressure. So early on, patients with diastolic dysfunction and patients with hypertrophic cardiomyopathy with diastolic dysfunction can have normal mean left atrial pressure. If you look at the E to E prime ratio here, it is not elevated, but you have that prominent atrial velocity and the pulmonary veins indicating that LV and diastolic pressure is elevated. It is a more sort of advanced stage of the disease. We have reduced annular velocities, increased peak TR velocity about 3 meters per second, indicative that not just the end diastolic pressure is elevated, but now the mean left atrial pressure is elevated. Finally, a restrictive phase of the disease. What I meant is restrictive LV filling, to be more precise. A very high E to A ratio, minute annular velocities, be it early diastolic or late diastolic. When this pattern is present, it is associated with a high likelihood of heart failure hospitalizations. More recently, we and others have looked at left atrial strain, and strain has been associated with events as atrial fibrillation, whereby reduced atrial reservoir strain and likely also pump strain with events of atrial fibrillation. What that slide shows is that the reservoir strain and the conduit strain are worse in patients with a peak oxygen consumption that is less than 80% of what is predicted for age and sex. This is taken from the 2022 guidelines. It starts the recommendations with atrial volumes, E to E prime ratio, and peak TR velocity. And if the totality of the evidence here, the majority of the evidence here is abnormal, it favors LA pressure elevation. If the majority of the evidence is not, then pressure is normal. There is an indeterminate possibility for left atrial pressure. What to do with these cases? If the patient is symptomatic and there are concerns, it is not unreasonable to consider cardiac catheterization to look at what is present. More frequently than not, you will see evidence in terms of pressure elevation when they go through cath. There are structural correlates of abnormal diastolic function, including the presence of delayed hyperenhancement, as you see in this case. With delayed hyperenhancement by CMR in the septum, you see quite low annular velocities and an E to A ratio that looks normal, but it's really pseudo-normal with a high left atrial pressure. Also, if you look at interstitial fibrosis in these patients, it is increased in patients with hypertrophic cardiomyopathy. Among the diseases that can be associated with a really large extracellular volume fraction, hypertrophic cardiomyopathy is one of them, and that was also related to exercise performance. As that extracellular volume fraction goes up, you see worse or lower peak oxygen consumption. Dynamic obstruction can be readily characterized in the cath lab, and you see here the ventricular pressure in blue and the aortic pressure in red, with big gradients. Of course, for us clinically or in the sequence of steps to evaluate these patients, we start with the physical exam that may say there is evidence of dynamic obstruction. And then we want to look at an echocardiogram to confirm that there is dynamic obstruction. I'll have few points to explain why dynamic obstruction happens. Again, there are some structural changes in these ventricles. First, there is an anterior displacement of the papillary muscles that brings the papillary muscles and the whole mitral valve apparatus closer to the septum. Then there is also mitral leaflet elongation. So many times these patients may have some degree of thickening, but more importantly, elongation of the leaflets. That elongation of the anterior leaflet combined with a reduced mobility of the posterior leaflet results in a longer segment of the anterior leaflet that is free from coaptation with the posterior leaflet and thus subject to drag forces that lift it up, push it closer to the septum and produce dynamic obstruction. So I highlighted issues with the mitral valve apparatus. The part on the ventricle that contributes to the dynamic obstruction include the septal bulge. So a thick septum as well as a sigmoid septum, in addition to increased contractility, contribute to obstruction. Why is it important to know that? Because each of these can be tackled differently when one is pursuing treatment of dynamic obstruction. There is work that shows sometimes you see severe obstruction despite the lack of significant degree of hypertrophy. Why? Because the issue is in the mitral valve apparatus. Patients with hypertrophic cardiomyopathy can have abnormal papillary muscles. This is an example of an anterior displacement of the papillary muscle that I showed you a cartoon of. This is a real case. And then you see a bifid papillary muscle that also can contribute to the presence of obstruction. That's a parasternal long axis view showing direct insertion of the papillary muscle into the anterior leaflet, almost no chordae. This is what diagnoses anomalous insertion of the papillary muscle. If that is present, then these cases with dynamic obstruction are best treated by surgery that can address the problem with the papillary muscle. Of course, you get a lot of details about PEP muscles also by CMR. And I will try not to delve more into that at this time. By M mode, we see contact between the anterior leaflet of the mitral valve and the septum. You see these arrows during systole. The longer the duration of the contact, the more severe the obstruction. We see it by 2D, and we put the color Doppler, and we have that inverted Y showing the acceleration through the LV outflow tract as well as the mitral regurgitation jet, which is typically directed posteriorly and laterally. Sometimes you see central jets and even anterior jets that may not be due to other problems with the PEP muscle. But if you see the typical pattern, all is well. If you see an anteriorly directed jet, you want to be more careful and look at whether there is something else wrong with the PEP muscle. I'll show you examples. We apply color Doppler. Color Doppler helps us locate the site of obstruction, and you do it in the parasternal long axis view, the apical 5-chamber view, and the apical long axis view as you see here. We also use mapping with pulse wave Doppler to verify where the obstruction is. Patients with dynamic obstruction can have obstruction at several levels, and it is important to distinguish obstruction at the level of the LV outflow tract from obstruction more distally in the ventricle. Sometimes you see the lobster claw in dynamic obstruction, and I refer you to the guidelines for the sake of time to sort of look into the mechanism of why this is observed. The classic signal that we teach is frequently that dagger-shaped LV outflow tract velocity, and you see a velocity here approaching 6 meters per second, but sometimes you see a rather symmetric LV outflow tract velocity because of dynamic obstruction. You may see this pattern or that pattern. During transesophageal echocardiography, you can also identify the presence of dynamic obstruction. We do not do TEE just to look for dynamic obstruction. The usual scenario where a TEE is done is if I am thinking something else is going on with the mitral valve and I want to identify that. But here you see it by 2D, the contact between the leaflet and the septum, and you see the acceleration through the LV outflow tract and that laterally directed MR jet, and this is similar to an apical 5-chamber view showing the MR jet with acceleration through the outflow tract. 3D can likewise be very rewarding in showing the presence of the SAM as you see here, and 3D allows you to get good assessment of ventricular volumes and mass in this disease as well as other diseases. At times, frequently, we get jets and you are questioning, is this a dynamic obstruction? Is that a mitral regurgitation jet? And I want to show you here, this is the dynamic obstruction jet. It is late peaking. It's about 5 meters per second. So if we do the modified Bernoulli equation, the gradient is 100. This is a case where we have the dynamic obstruction jet superimposed on the mitral regurgitation jet. This is a velocity approaching 7 or maybe even more than 7 meters per second. That's the MR. But the distinction between where the outflow tract velocity peak is versus that peak of MR is not that clear. So what do we do in these cases? So I'll take you through a sort of a process that you can all do that helps you be more comfortable with reporting what the actual peak gradient is. So this is a patient who has both the dynamic obstruction and the MR, and we said that's what you will usually see, and we have a peak MR velocity of 7.5 meters per second. We will assume LA pressure is 20 millimeters mercury. I'll come back to that assumption and whether it hurts you that much if you give 20, 10, or even 0. And then we measure the systolic blood pressure with the cuff of 170. We make the assumption that the systolic pressure of 170 is the pressure in the root of the aorta. It's an approximation, but for now we will be satisfied with it. Then we do the modified Bernoulli equation for the MR jet, and we say LV pressure minus LA pressure is 4V squared. The interest here is in LV systolic pressure, and so we say 4V squared. In this case is 4 times 7.5 meter per second squared is 225. I rearrange the expression. Now I can say that the LV systolic pressure is 245 millimeters mercury. Then we take it back and we say, what was the systolic blood pressure? The systolic pressure in the ventricle minus the systolic pressure is the gradient across the LV outflow tract. And so 245 minus 170 means that the LVOT gradient should be at least 75 millimeters mercury. So this is a sizable gradient. Other causes of obstruction can be present as aortic stenosis, and that can be assessed with short axis views. Typically, transthoracic is sort of a clue, but not really that reliable. There was a time when people were interested in doing planimetry of the aortic valve through TEE, but now there are other imaging modalities that can address that. Sometimes we see patients referred who have both dynamic obstruction and aortic stenosis. That's an example from a patient with dynamic obstruction with a Valsalva gradient about 2.5 at most. And then take a look at the aortic stenosis jet. It's approaching 3.75 or so. If we take a closer look, this is a late peaking signal. This is an early peaking signal. That tells us this is a dynamic signal. This is a fixed obstruction signal. If a patient has a subaortic membrane, their signal will look like that of an aortic stenosis because it's a fixed obstruction. Having said that, again, you can see cases with coexisting subaortic membrane and dynamic obstruction, and that shows sort of the superimposed. The brighter one is the LVOT gradient, the fainter one here is the aortic stenosis. Example for a case that was referred with the diagnosis of hypertrophic cardiomyopathy. There was a suspicion of a subaortic membrane, nicely shown here by transesophageal echo, and we see the fixed obstruction signal with continuous wave Doppler of aortic regurg, which is not uncommon in patients with subaortic membrane. This is a case where you see mid-cavitary obstruction in addition to LVOT gradient. Color Doppler tells you where the obstruction is, and in terms of an absolute value for that gradient, not much, but sometimes these reach very high values. When we see someone who's symptomatic and we do not have a gradient at rest, we routinely look for provocable obstruction, because if there is a significant degree of provocable obstruction, they are candidates for treatment. There are many tools. The ones that we rely on day to day in the lab is the Valsalva and then typically exercise. That's from the cath lab showing a PVC, and then post PVC a very large gradient with much reduced pulse pressure. If you happen to have a PVC, say during a routine transthoracic study, you may see that, but obviously easy to induce in the cath lab. And so that's a recommended algorithm on how to approach cases to look for provocable obstruction. It all starts with symptomatic patients. So they have to have symptoms, and then we look for gradient at rest and with provocation. On the resting echocardiogram, if we do not get the magic number of 50 millimeters mercury, we refer them to exercise stress echo. If the gradient is at least 50, then they have what we call obstructive hypertrophic cardiomyopathy, and they are candidates for all treatments you offer patients with obstruction. If not, then you repeat the study in 1 to 2 years. Sometimes you see patients who do not have a significant obstruction 1 year, then their symptoms are worse, and you reassess them, and the obstruction indeed meets the target at which you would want to do intervention. Few points about mitral regurg. In many patients, it is related to obstruction, and in that case, the jet is usually directed posterolateral, but as noted earlier, sometimes it can be seen as central or anteromedial jet, and if there is no mitral valve pathology, myectomy can take care of the mitral regurg without a specific intervention on the mitral valve. However, mitral regurg can also occur due to something separate from hypertrophic cardiomyopathy, so a prolapse, a flail, or infective endocarditis. Before we embark on treatment, particularly if I am thinking of septal reduction therapy, I want to know what is the mechanism of that mitral regurgitation. If it's a case, say, of a flail leaflet, then obviously that's a surgical candidate, and the surgeon can then attend to both the mitral valve and the myectomy. If needed, you can proceed to transesophageal echo, or CMR can also provide valuable information about the morphology of the mitral valve and the mechanism of the MR. That's an example of a flail segment of the posterior leaflet, and you see a large anteromedial jet. Mid-ventricular obstruction is an entity that you will see as you see more and more patients. It was noticed in about 3% of the patients in a recent registry, a multi-center registry. The way we define a significant mid-ventricular obstruction is the presence of a gradient of at least 30 millimeters mercury. We need to look carefully not just at the mid-ventricle, but also at the apex. And so for echo, we rely on flow signals Doppler in addition to ultrasound enhancing agents. CMR is ideal as well to look at these cases. The presence of an apical aneurysm portends a higher risk for mortality and ventricular arrhythmias, and in and of itself, irrespective of the size of an aneurysm, is considered a high-risk function that should trigger a discussion of ICD implantation with these patients. That's an example with echocardiography. You see the mid-ventricular obstruction, you see the apical aneurysm, and it has a clot. look at it by CMR. Again, you see the mid-ventricular obstruction, the apical clot, and after anticoagulants a couple of years later, that is not present anymore. Of course, these cases, if you recognize the clot, they should be on anticoagulants. Risk stratification for sudden death, you want to look at maximum wall thickness. It's not sort of rigid 30 millimeters or 29 millimeters or 28 doesn't meet the standard. Give and take the 1 and 2 millimeters in the management, in the measurement. And so you may also refer that case where I measure at 28 millimeters for ICD consideration. Apical aneurysm, we're looking at high event rates, 5 to 15% per year. A LGE total burden exceeding 15% is one of the factors that comes into play when you entertain whether you recommend ICD implantation or not. The European Society of Cardiology came up with a sudden cardiac death calculator, and in that, the left atrium anteroposterior diameter is factored in, I would say more frequently than not. Atrial size is related to atrial arrhythmias and heart failure as opposed to sudden death events. The same applies for LVOT obstruction, be it at rest or with Valsalva, and EF of 50% or less is pretty concerning, and also would trigger evaluation for ICD implantation. There are very small studies that looked at the presence of ischemia and reduced blood flow reserve by PET, and that was associated with worse outcome events. These have not been repeated. However, and as a result, we do not routinely send patients to look for the presence of ischemia or flow reserve by PET. That shows you the data for the increased wall thickness. Notice that even a 16 to 19 millimeters is also associated with incidence of sudden death. Most deaths, actually sudden cardiac death, do not occur in those with the very high wall thickness. They occur in the mid and lower ranges, highlighting the importance of looking at the other factors. There are clinical factors that I haven't emphasized here. LGE and its association with sudden cardiac death with total mortality as well as end-stage cardiomyopathy. I won't dwell on that. Example of an apical infarction recognized with LGE by CMR. Ischemia and CAD evaluation, you all are familiar with PET, and you can see perfusion defects by PET due to microvascular disease, not due to epicardial coronary artery disease. Having said that, if you see, say, someone who is symptomatic, older individuals, risk factors for CAD, it is very reasonable to say I'm going to proceed to CTA or angiography to look for it. This is a nice example with CTA showing the presence of a myocardial bridge, and sometimes these can be associated with problems, and in some centers the surgeon will attend to that as well during the operation. That's a chest pain workup. I will not dwell on it, but you can appreciate that it includes the tools we just talked about to look at perfusion. We mentioned CT angiography, we mentioned PET, MRI also can be used to look for ischemia. I trust Dr. Mann will get into that. So when we treat patients for dynamic obstruction, we can use medical therapy, of course. We typically do imaging at 1 to 2 years interval. Anytime there is a change in symptoms, you want to look sooner. Perhaps a patient who has not had obstruction in the past now has obstruction that you can treat. And specifically, we are looking for that gradient. We are looking for ventricular size and function because a subset of patients can develop what we call a dilated hypokinetic phase of the disease. Again, that would trigger a different treatment approach. For patients who are on myosin inhibitors, as you initiate treatment and as you maintain treatment, you do serial echocardiograms to look at the gradients and ejection fraction, and these are used to titrate the dosage of the drug up or down or even withhold it, depending on the cutoffs. During surgery, they are looked at. Ideally, you know the details of the hypertrophy pattern before the operation by echo and CMR, but during the actual operation, the surgeon wants to know not just how much the thickness is, but also the length of the thickness as you go from the aorta towards the apex of the ventricle. A good operation resects the proper amount of length, if you would. Otherwise, you would end up resecting from here, and then the leaflet touches and causes obstruction more distally. We also use transesophageal echo. This is done by anesthesia to look for problems that can develop, for example, a ventricular septal defect, which is not present here. Alcohol septal ablation is done with transthoracic echocardiography, sometimes done with transesophageal echo. And we used to rely first on ultrasound enhancing agents. Nowadays, the actual radiographic contrast is agitated and is used to produce brightness in the septum. That's an example where it has already been injected in the cannulated septal perforator through the lumen of the balloon. And you see that the area of brightness matches the area where flow acceleration is taking place. Want to show you here, this is by transesophageal echo. This is a case where we see the opacification happening on the LV side, if you would, of the septum, and that's a good location. In comparison, this is another patient where the opacification is happening on the RV side, but the LV endocardium is not that much opacified. That's not an ideal vessel to inject ethanol in, because if you do, you will produce infarction on the RV side, but you will leave the LV endocardium and myocardium unaffected. Sometimes the septal perforator supply structures that you do not want to induce infarction on. This is an off-axis view done with an ultrasound enhancing agent, and you see here the papillary muscle actually being highlighted. The injection in this septal perforator was aborted. For that reason, and angiography at the end of this of the procedure, you're looking to see what happens to the septal perforator, and this is before, this is after you see the vessel amputated, and there are the gradients before. Here is a probe between 5 and 5.5, and here you see early peaking, so there is no dynamic obstruction with successful alcohol septal ablation. You see improvement in diastolic function with this procedure. This is a mitral inflow consistent with a high LAP before ablation, and this is consistent with a normal LAP after ablation. And there is a peak TR velocity of 3.5, so RV, RA gradient approaching 49 millimeters mercury, and now it's 20 after that successful ablation. So it could be effective treatment for patients with heart failure. In situations where the septum is not that thick, alcohol septal ablation and even myectomy can carry a higher risk of inducing a VSD. And so there are approaches whereby you can limit the mobility of the anterior leaflet of the mitral valve so it doesn't meet the septum. It's a transesophageal echo showing you some aortic regurg, you see the acceleration in the LVOT with MR and the dynamic obstruction. This patient underwent a clip deployment, as you see here, and after that successful clip, that gradient, which was almost 5 meters per second, is completely gone. So it's another tool that is available for these patients. So in the end of my conclusions, Dr. Mann will elaborate on CMR. Imaging is essential in the evaluation of these patients who are referred whether with a known diagnosis or suspected diagnosis. However, many times the clinical piece is needed to establish the correct diagnosis and sort out through the differential. It plays a critical role in informing risk stratification for sudden cardiac death and the evaluation of patients with chest pain and possible CAD. It guides treatment with negative inotropic drugs, septal reduction therapy, and transcatheter edge-to-edge repair. The staff of the imaging labs should have a clear understanding of the strength and the limitations of the different imaging modalities so you can recommend what is the next step that is needed. We should also know what are the clinical implications of the findings that we have. For example, someone with dynamic obstruction and a septum of 1.3 or a maximum wall thickness of 28 and so on. The report should be clear and the results should be communicated clearly with the clinical team taking care of the patient. Thank you.
All right, thank you, Dr. Nagueh. And I'm going to talk about CMR and the assessment of ACM. And If only Dr. Kleiman was here to shift all of you forward. All right, so here's your QR code. So we're going to talk about diagnosis of HCM by CMR and nuances of assessment. We're going to talk about secondary findings related to HCM. Some of the phencopies, there's many, and we're going to cover some. And then some recent updates, and we'll have cases in between. So there's a lot of updates nowadays with imaging from the ASE guidelines with Dr. Nagueh, and then there's also a new 2024 guideline from the ACC and AHA. In terms of when to use CMR, some of the highlights is that when there's suspicion of having HCM and echo is inconclusive, you would want to perform CMR for clarification. And then if there's LVH and suspicion of alternative diagnosis, and this is where the key indication nowadays is for CMR tissue characterization, you really have to strongly consider MRI, and it's become near standard of care, particularly for older individuals without genetic mutations where there's a litany of alternative conditions, and you don't want to overcall HCM in everyone with hypertrophy. So here are some case examples. So here's this patient with asymmetric hypertrophy, sigmoid-shaped septum, and you notice that there's also a bit of a subaortic membrane. You see the flow acceleration. There's no clear-cut SAM. What do you guys think this is if you just had one morphological assessment? HCM, maybe not HCM. What if I told you she had a gene positive evaluation, so she has one of the sarcomeric mutations of HCM? This actually eventually turned out to be chloroquine cardiomyopathy. So when you add the tissue characterization to these cases, and I'll show you actually the remainder of this case a little bit later on in the talk, you actually find that particularly for a lot of the older individuals, and this is what I want you to keep in mind, alternative diagnoses are also actually quite common. Here's this case also asymmetric hypertrophy, sigmoid septum, no SAM. This actually turned out to be amyloid. Let's go through these three cases. So very mild hypertrophy. If you actually measure this, you may only get 1.1 because there's this big moderator band like Dr. Nagueh discussed. You don't want to start measuring from here all the way down here. And then here's a similar case, no SAM either. And then here's this case. You see global hypertrophy, worse in the septum. What do you guys think this one is? Do you think this is HCM, or do you think it's not HCM? You don't have to give me diagnosis based on one picture. I didn't make the diagnosis based on one picture. But do you think it is HCM or not HCM? How about this? Oh, I can't hear you. All right, good. So you see there's RV hypertrophy also. And this is really unusual. You may have papillary hypertrophy in the RV in HCM patients, but this is kind of unusual. And then you see this, hypokinetic phase. So actually, all of these three cases were sarcoid. None of these was HCM. So this is where, keeping the clinical picture in mind and ancillary findings, as well as the tissue characteristics on MRI, which we'll get into, are very important to differentiate HCM from non-HCM. All right, so other indications. So you're going to try to assess maximal wall thickness, EF, apical aneurysm, which has become very important in the past few years, and then the extent of myocardial fibrosis or scarring. These are also key indications for MRI. And then the sudden death risk assessment with MRI, and particularly also potentially for follow-up. So it's not a one-time test that many patients will get, but particularly for younger individuals, you may end up having to do follow-up MRIs on these patients, not just one. Because LGE over time can change, as well as other findings, and which we'll get into. So here's an example, 47-year-old, no family history. From what I remember, normal EKG. He has he has history of asthma and history of hypertension. His wall thickness was 12 millimeters here. And then if you measure it this way, which is less preferred, you get 1.5. So kind of borderline, particularly with negative other evaluations. You recommend another test for this kind of person because you want to follow them over time, particularly when there's uncertainty based on the first evaluation. So 2 years later, now his wall thickness is 1.7, and now he's clinical HCM, essentially. All right, so this is how we kind of do an MRI in general. So you get anatomical assessment. Those kind of nice cine images are what we call SSFP. We do what's called a high-resolution 3-chamber view to look at the mitral valve and the LVOT. We very often do a vasodilator stress perfusion, followed by flow assessment, and then we do the delayed enhancement. In terms of measuring wall thickness, this is a very nice recent study that actually got, a bunch of volunteers that are all experts throughout conferences, and they had people do paired studies of MRI and echo, and hey, just measure the LV wall thickness for me. And you see how everyone measures it a little bit differently, and everyone will measure it on the long axis versus the short axis. Do you include this RV moderate band? Do you not include it? Do you draw the line tangential to the LV segment versus perpendicular to it? So what they found is you could potentially modify the recommendation for ICD, primarily on the wall thickness side, in 1 to 7 patients. So there's a lot of variability in this, and this is why when you're doing repeat studies, you want to make sure you look at both studies. If someone measured 1.8 and then now you're measuring 2.0, it is very likely that the patient hasn't actually changed and you're just measuring it differently. So this was shown by Dr. Nagueh already. Those 3-chamber views are actually cut kind of in this angle, so you're going to get a larger wall thickness from this angle versus this angle. Now, I will argue, that 30 millimeter recommendation for ICD, that probably came from measurements like this. So if you start now using these, I honestly don't know if you may run the risk of starting to sort of underreport wall thickness. But, I'll get into that a little bit more as we show some more cases. So these are kind of the typical patterns, and as you notice, the reverse curve pattern is actually less likely to have LVOT obstruction and SAM, but you have massive hypertrophy. They're more often gene positive, and then you have the apical HCM and then the typical pattern of sigmoid HCM. More recently, there was the CMR registry, which I believe Dr. Nagueh also participated in. They found those 2 major patterns across a large cohort in North America and Europe. And then those reverse curve patients, more delayed enhancement, less likely to have LVOT obstruction because you don't have that basal sigmoid septum and narrow LVOT that predispose you to having SAM. And then they found essentially an overall similar distribution where you have the majority being sigmoid septum or reverse curve, the apical hypertroph and these massive hypertrophy with mid and apical cavitary obstruction are less common than this. And then the more rare and less common is these kind of lateral wall hypertrophy or concentric hypertrophy. And here, when you have an older person with, hypertension and multiple comorbidities, you also have to be careful and not overcalling these kind of patients HCM. And here, really, the clinical history and LGA findings are really very important. So here's an example of a patient we scanned, a 30-year-old. Notice he has the reverse curve pattern, no LVOT obstruction. He has symptoms. We do the stress test, and you notice kind of heterogeneous perfusion abnormalities on stress that don't necessarily follow a clear-cut coronary pattern. They're very often in the hypertrophy segments. And then obviously by taking a look at the patient's clinical risk factors and age distribution, you can try to stratify if this is related to microvascular disease and myocyte disarray that can happen in ACM versus epicardial coronary stenosis. Now, why this is relevant, and these are the LGE sequences in this patient, there's a relationship between having perfusion abnormalities and future development or progression of LGE. So this patient was scanned in 2013. He was very young. I think he was 22 or 23 here at the time. He had a wall thickness of 1.4, no LGE. And then in 2018, now his wall thickness is 2.2. He developed LGE, But notice his perfusion at the time of the first scan actually showed perfusion abnormalities in this that will later manifest as LGE. And then there's smaller observational studies that show these perfusion abnormalities relate to the progression of LGE, essentially. Associated abnormalities Dr. Nagueh discussed. So look for the elongated anterior leaflet. Some patients will have concomitant MVP, and then aberrant insertion of the papillary muscle. Notice this area here actually is not all of the anterior septum, but it's actually the anterior papillary muscle being anteriorly displaced and also inserted very high up here. And then you have to look for the other abnormalities, such as also these accessory cords and the bifid papillary muscles, and these sometimes can be better seen by TEE rather than CMR, because these sequences are done over multiple heartbeats. So if you have a highly mobile structure that is moving somewhat randomly, you may not be able to see it very well. And obviously the temporal resolution is going to be lower. So tissue characteristics, this has been noted all the way back in 2000 and in the early 2000s. And essentially, the distribution of LGE in HCM is very often in the RV insertion site, in the hypertrophied segments. But then as the patient gets into end-stage HCM, it becomes very difficult to differentiate, is this scar pure HCM or is it something else? And extensive LGE has become one of the key indications, but it's not one of the main ones. We'll also argue that that 30 millimeter cutoff is in a way a corollary to having high scar burden. So those two are concordant very often. So from that early study in this back then small series of HCM, you notice that the presence of scar is higher as the wall thickness goes up. In people in segments with normal wall thickness, it's unlikely to have a meaningful scar. That can be also related to systolic function at the segment level, as well as EF and LV mass. And there's multiple patterns, as you see here. When you get to stages like this, it becomes difficult sometimes to differentiate, in an older person, or is this sarcoid or is this amyloid versus HCM. And as Dr. Nagueh showed, once your scar burden gets to a higher level, 50% or so, then your risk of sudden death becomes meaningfully higher than those without scar. This was also shown in multiple series since then. This is a series that kind of took people with normal EF and what was considered kind of low to moderate risk HCM. And they show essentially stratified by getting myectomy versus not. If you have extensive scar but you get myectomy, your long-term risk becomes lower and becomes similar to those with extensive scar. There's also recent changes or improvement, if you will, looking at radiomics. So this is kind of looking at the texture of LGE findings and trying to improve the risk stratification of sudden death risk. And in this model, they were able to improve beyond just quantitation of scar and the ESC or AHA model. This is another update. So there's an entity of people with loss of apical tapering. So in all normal hearts, you notice the apical segments become very thin. And in some patients, they would have apical segments that are not 15 millimeters, but you don't have that normal loss of wall thickness. So if you have to wait for everyone to get to 1.5 centimeters to call them apical HCM, you may end up with some cases that have all features of HCM, but don't meet, quote, the imaging criteria of it. So this was found a few years ago by noticing a group of patients with abnormal EKG, deep T-wave inversions, and some of the characteristics of HCM, but not a 15 millimeter threshold for HCM diagnosis in the apex. So using the UK Biobank as well as this group, if you use that loss of tapering and an index value of about 1.5 millimeters per meter squared, so essentially using 11 millimeters wall thickness in the apex and loss of apical tapering, you can detect these cases better. So I'll show you this example. So you look at this EKG, patient is older, history of CAD, hypertension, and essentially you notice in his apical segments, you notice that there's no tapering of the LV wall thickness, and this is kind of unusual to see in someone with just plain hypertension. Notice the two-chamber view here with these segments. He had mild scar in these areas, and this is kind of an example of this kind of scenario. So keep an eye out for this, and obviously when you see these patients in clinic, you have to consider this also. I'll leave you with a couple cases. So here's a patient I called HCM just a few weeks ago. So you notice there's heterogeneity, or not heterogeneity, there's this segment here in the basal septum that's thickened, but actually, if you look at it kind of at the tissue level, notice that it has a different texture compared to the rest of the LV. And now in hindsight, you know, it has clear borders. So this patient actually has a tumor in the basal septum. And this was considered a benign tumor. Notice that there's brisk uptake with delayed enhancement of this segment. And now it's been stable for the past 8 years. So this is a benign intramural tumor rather than ACM. Here's that case that I showed you earlier. So 71, gene positive. She has family history also. She developed, asymmetric hypertrophy over the prior couple of years. She also has rheumatoid arthritis. And essentially, what we find is the pattern of LGE that she has is a little bit unusual for HCM. So notice scattered, diffuse HCM that is intramural. Notice this in the apical segments where she has this midmural enhancement. So we said, this could be seen in HCM, but, a concomitant alternative disease is possible still. And, when they reviewed her history, because she's been on Plaquenil for many years, she ended up getting a biopsy that showed the chloroquine cardiomyopathy. She had a repeat MRI after they stopped the therapy, and that hasn't really changed meaningfully. All right, so it's become near standard of care nowadays to get MRI in people with suspected and established HCM, particularly for scenarios when the diagnosis is uncertain, follow-up in younger patients, assessing evolution in LGE, and then obviously inferring or further enhancing the SCD risk stratification, and then keep an eye out for these unusual presentations. All right, questions? All right, see you all next week.